We now take pride to welcome our next dynamic speaker, respected Dr. K. Swaminanthan, sir, to explore his groundbreaking ideas to the participants. We also welcome the chairpersons of the session, respected Dr. Suresh, sir, Professor and HOD, Department of Anatomy, and a sparkling MU coordinator, Government Vellore Medical College and Hospital, and energetic respected Dr. Gauri Shankar, sir, Professor and HOD Department of Surgery, Government Thiruvannamalai Medical College and Hospital, to introduce the speaker.
A very good morning to you all. It gives me an immense pleasure and honor to be here amidst the most illustrious crowd of the educationist. And over a period of 1,000 years, if we just have a glimpse on the history, we are not surprised to see most of the learning and teaching methods have been occurred during the workplaces. So this is very much relevant even in the medical education nowadays. So there was a question posed by a renowned surgeon of the early 19th century, Dr. William Stewart Halstead. He has posed a question: can I trust my attendees, my trainees, or my residents in doing a specific critical clinical task unsupported or unsupervised? And this is posed in developing an entity called Entrustable Professional Activity, which encompasses all the competencies across the domains and also the milestones and benchmarks. And this EPA is going to be a measurable one, reproducible one, and amenable for evaluation and assessment. And the next session is going to be about this entrustable professional activity. And sir will be introducing the speaker.
Good morning, all. Competency-based medical education had a major shift in training the trainees and the way they have been educated. The cornerstone of the concept is a EPA. Okay, I have immense pleasure in introducing our speaker, who is having 30 years of experience in academic as well as research activity, and he is presently holding a director of Institute of Pathology in Madras Medical College, and also he is authoring a book called Textbook of Pathology and Genetics for Nurses. Please join me in welcoming our speaker, Dr. K. Swaminanthan.
Yes, thank you, chairpersons, for this lavish introduction. And thank you, Team DEEPAM, Priscilla and Anjana, for this kind invitation and who made this possible. And all my seniors are there. Lata ma'am is there, Deepti is there. So I find bit thing, should I present this or not? Because I'm not that great in doing, but I've been working on this EPA for my specialty on pathology. So I thought, as Raja Pratibhan said, we start with a project and we get something and we want to share it. One way is to publish, the other way is to talk with them. And I found this is one of the very good platform where I could do. So without much delay, let's start off with my thing. Trust. Trust is very important. We need to be trusted. It plays a very, very important emotion in all fields, particularly in our field also, and we need to be trusted. Think about this scenario, this question we can ask for ourselves. When was the last time we confidently allowed a postgraduate resident to perform a task independently without feeling to step in and cross-check? Have we done this? we are all PG teachers of quite a lot of experience. We're done, we're trained. My postgraduates are here in Thiruvannamalai. HOD and the other associates are my proud students from Tirunelveli, Dr. Radhika and Gayatri. But are we confident? Think about it. Are we training? The second question in my mind is, are we training our postgraduate? Because this EPA is mainly for postgraduate, but we can also use for undergraduate for the certifiable skills. Are we training the residents to perform the task independently? Think about it. Next. This happened in Madras Medical College 2 months back, and this was in the papers. A PG resident posted in casualty. He shifted the case to the ward without asking his supervisors, and the patient collapsed on the way to the ward, and it became a huge cry. Who gave permission for the PG resident to shift it? Did he ask him what he did? Lot of things were there. The PG was suspended, the association came in, lot of things happened. We'll not go into that thing, but this is one issue which again depends upon trust and when to trust. So this background ideas should make us think that are we doing, we are teaching them skills, we are assessing them, we are doing everything, but are we doing in a structured and methodical manner, and can we depend or do we create a sense of ownership among the learners that he will be able to do the task by himself confidently? This was entrustable professional activity. So to split this into much more simpler thing, these are acts which require the trust. Who should trust you? It could be your colleagues, the public, or the patient. And it must be professional. The acts should be confined to the occupations. And these are activities which has to be done and shown. So my plan for this next 30 minutes will be, we'll just start off with what are these EPAs, how are they used, and how to differentiate this from competencies, and can we create our own EPOs in our specialty? Yes. And if we create it, how do we validate it, and how do we put them into action? So this concept was introduced in 2005 way back in Netherlands, and by definition of CATE, these are units of professional practice which could be entrusted to the trainee as soon as he or she demonstrates necessary competence to execute that activity unsupervised. This is the definition for EPA. So what does it do? We already have competencies, we already have milestones. What are we achieving by this EPA? It shifts the focus from individual competencies to work that must be done. In other words, it makes the competencies to work, and it provides a roadmap for training in our clinical practice. He is the person, Swaminanthan, who pioneered in EPA, who put forth this concept from Netherlands. Still, he is doing a lot of paper on it. And think about these cartoons from Hindu mythology. What do they say you? What are these? Yes, anyone? Is it so complex? I think I put so many pictures. What system it is? Guru, excellence. So Gurukul. So our EPA is related to Gurukul. Are we touching the roots of us? Because in Gurukul, if you go back and see, they are not just taught by lectures, or they don't have. There is a continuous process of learning where there is a constant and continuous practice, and where the tasks were slowly given to them, and first under supervision, and then they were allowed to do it unsupervised. This EPA is my observation. And to make it very simple, is every day, what constitutes EPA? That's a bit, because whenever I talk about EPAs to a set of people, already we have competencies, sir. They'll start. So So to make it very simple, I'll say this is everyday's physician activities, my acronym for EPA. Like in pathology, what do I do from morning to evening? Grossing up surgical samples, reporting on a smear, doing a marrow, or doing an intraoperative consultation. So this is all about the definition of EPA and something on it. Then, as I told you, then why this EPA? Because there must be, it links a progressive proficiency to progressive autonomy in patient care, and the readiness to practice is very, very important. We just pass the candidate and we don't know how much ready he is there to when he is thrown out in the field. And here, this system of EPA, it works on prospective assessment or in some way. About this Miller's knows how, shows how, and does. Now we have the extended Miller's or the revised Miller's, where the topmost one after does comes the trust. Do we have the trust? How are we going to trust? It is all about our EPAs. So it's a step. We can't achieve that mastery in a single day. So where we need stepwise, there comes the milestones which we already do, which we already been doing this for a successful career. Okay, so the residents are given responsibilities. They are made owners of their own learning, and with that, they are able to control what they are going to do in the real-time practice. Okay, next comes a question which a lot of people ask me. Are EPAs and competencies the same? Because both will be able to do. Fine. Are they same? So just I like to make a clarification. Competencies are statement which makes the learner to ensure the learners acquire the ability. He will be able to do a particular task. And our responsibility as teachers or facilitators is to see to that he acquire that particular ability to do the task. But the caveat here is it does not guarantee whether he will do the same way in a real-time situation. So, how do we differ? There's a small difference between competencies and EPAs. So, I'll give an example. Malik can fly an aeroplane is a competency. We certify that he has got the skill to fly an plane. But EPA is, you ask this question, would you like to fly with him? What sort of trust you have on him so that you drive? That is the difference between competency and an EPA. Coming on to my pathology proper, same thing. So there's a competency statement in NMC curriculum is interpret and correlate clinical and laboratory data so that the clinical manifestation disease can be explained. This is which is there in the NMC. So this can be, when you convert this into an EPA, it's broken down into individual tasks, reports on a peripheral smear, reports on a bone marrow, something like this. So competencies we already know, they are specific, they are learnable, they're integrative, they're mutually dependent, and they're durable. And the outcomes, we already know about our SMART outcomes. So competencies are building blocks for the EPAs, and there is a transfer of responsibility to an entrustment. That's what we have to. So what do we need? So we already had a gap, as Lata Madam said. First, identification of gap is very important. We identified it because there was a gap between the process and the outcome. and CBME was brought in, which was an outcome-based approach in which we tried to bridge the gap, but there was still some gap, which could be, one of the tools could be our EPAs, wherein we certify him, wherein we trust him and put him to the field so that we assure that quality care is given. So the scope of EPAs, they are very broad and they reflect the acts of professional practice. They integrate multiple competencies, and assessment is multiple, it is continuous, and it is going to be a prospective one. And the other developments, or what other thing that happens is development of professional identity, autonomy, readiness to practice, all of them happen as an effect of this EPA. So EPAs is an activity, is a task, and EPA is not a competency. So what constitutes an EPA? As I told you, it must be a professional activity, it must be a discrete activity, it must be observable. Both the process should be observable and the outcome should be observable. It must be measurable, and it needs training for the trainee to perform it. So this, it goes with the mnemonics, promote. Whatever I said, it can be put in a mnemonic as promote. Okay. So I put 3 tasks. Of these 3, which is not an EPA? Inserting an IV line, performing a lumbar puncture, measuring a urinary output. Which is not an EPA? Of course, the third one, because it does not reflect it. So as I already told you, it comes. Okay. How do we, so now we know about EPA, what are the factors of why do we need an EPA, and how do we create an EPA? It's again a job which we could do as a department. So we know every specialty has got certain activities which we think are very core to a specialty, and as I told you, it has to be executed independently, should be observable and measurable. So you first identify all the like-minded people in the department, sit together, you take the curriculum or your competency list, and you jot down the activities which you think are core to your profession. And so, for example, it could have multiple competencies linked. For example, if you have the EPA on resuscitation, it will have competencies on medical knowledge, competencies on patient care, competencies on procedural skills, and interpersonal care. So it will have multiple competencies which we already know. Then once you are done it, then you make a list, then you make milestone. How am I going to ensure that he reaches that level of entrustment? I develop what he will do when he enters the course. First year, what he will do, what skills he will learn. Second year, what skills will learn. When I will ask him to do it independently. So that are the milestones which we develop based on the EPAs, what we have shortlisted. So we already know the milestones are gradually we take him through the process until we give the entrustment. So this is how a lot of milestones. One example of milestone from gynecology. This is how we develop the individual milestones for the concerned EPAs. Then trust. There are 3 types of trust. The first one is presumptive. We presume that he will know, he will do. Something happens in our mind, we presume that thing. That is called presumptive trust. Second one is initial trust. If he does the first task properly, we assume that he will also do the other task properly. That's the initial trust. Both are dangerous. What we need is what we call a grounded trust, which is based on multiple data points. We collect data, we see him, we observe him, we get feedback, we give him remedial, we take multiple points, and then we make a summative entrustment decision, which is very essential for the success of this EPA. Okay. Then what are the levels? As I told you, how he progresses. So we have the level 1, where he's just an observer, he's novice. He just sees the procedure, that's all, or sees a skill. Then level 2 is, he does the skill under proactive supervision. Then level 3 is, he's ready to perform the EPA under a reactive or an indirect supervision. Level 4 is he is ready for an unsupervised practice. So for the skill set or the EPA skill set which we have developed, we need our postgraduate to come to level 4 for certain skills and to level 3 for certain skills, and level 5 is where he serves as a teacher and teaches his juniors and peers. So when we equate this to the PG residence journey, probably the first year or the entry is level 1. Then at the end of first year, he becomes advanced beginner or level 2. Then at the second year, end of second, he becomes level 3. Then by his exams or by the third year, he becomes a level 4. And once he reaches the desired level for that particular EPA, he is awarded the STAR. STAR stands for is a mnemonic which stands for Statement of Awarded Responsibility. Okay. So what must an EPA contain? Certain things, because of the confusion between the competencies, we make it very clear. How should we write an EPA? So every EPA must have a title. It must have specifications. What does it mean? And potential risk if it fails. Suppose what will happen if you're given level 4, but he fails the next time? What will happen? That again has to be jotted down. What are the competencies which are involved, which contribute to the EPA? What knowledge he needs, what skills he needs, what sort of attitudinal changes he needs, that has to be listed. And how do I assess it? What are the information sources I have to assess his progress in that particular journey, and what level he has to reach for that particular EPA, and how long what is the period of expiration? Whether it's for 2 years, can we certify, or whether it's for 3 years, based on the skill, we decide the period of expiration. So that the title must be very clear, not more than 10 words. It must be very concise and understandable. And specifications the document should be very clear to say what I mean by writing this EPA, and what are the what it will not include in that particular EPA. I must be very clear in that statement. And what the third one is failure. What is going to happen if a trainee who performs in level 4 fails to do the activity as expected? So what will the department do? How are we going to manage that? That again has to be put up in the document. And again, domain, we already know the domains of an Indian medical graduate. So we had to scale it down to which domains it involves, the particular EPA involves, and what prerequisite knowledge he needs to execute the EPA, and what sort of training he needs to execute the EPA has to be thing. And finally comes, how are we going to do the multiple observations, whether it's going to be in the form of a cognitive assessment, or whether it's going to be a workplace-based assessment, or whether we're going to assess individually through the portfolios, logbook, or reflection, multi-source, what sort of tools we are going to use to make that summative entrustment decision. Then validation. This again very big, because it's so simple. We start writing around 30 skills for a pathology postgraduate. I'm happy, but I can't be happy because those has to be validated. The other people should say, okay, that's it's an EPA. So I need to validate my own EPA. Again, we sit together. So we have to ensure that the EPA is in alignment with the educational goal. It is reliable, it is consistent, it is feasible, it's appropriate, and it has got an educational impact. How do we do? There's a lot of ways to do it. So one way is to apply the equal rubric, where we have the 3 construct, there are 14 items in it, which is based on the task, outcome validation, and framing. So we apply the equal rubric and we say whether our EPA passes this validation checklist. So the 14 for the thing, this EPA has got a clear beginning, which means the task is discrete, whether it's specific, whether it's individually executable, whether it's observable, whether it's measurable, whether it leads to, we need to have an educational impact or an output for that EPA. whether it is a suitable work to be entrusted and whether there is no overlap between two EPAs in the same specialty. Whether it's core to the profession, whether it acquires application of knowledge, skills, and attitude, whether multiple domains of competencies are involved, and EPA title describes just the task. It will say he will be able to prepare the peripherals in a correct manner, accurately. No, we don't do those adjectives. Just it will indicate the task. And as I told you, it avoids adjectives and verbs. But a simpler way to what we decided, what we made a checklist from the equal rubric is we have the checklist with us. So whenever we propose an EPA, we just see this checklist and we say, when he passes out all the things or whenever we have an issue, we talk and we discuss it and we make suitable alterations in the wordings of the EPA so that it becomes workable. Same thing we do. I think we use 2-3 formats for our validation to see to that there is no overlap or redundancy. Okay, as I told you, the entrustments could be, it could be ad hoc entrustments which are taken every day and which doesn't have a longer consequence. And what we need is to have a summative entrustment decision. This is again very, very important. Just creating an EPA and putting in the prospectus of our institute does not serve the purpose. We must have a robust assessment system which will say, okay, fine, this is functioning. So as I told you, it's multiple assessors, multiple times, multiple data points, and it's so we have to document everything because we are going to. It's a very high stake decision which we are going to take. So I'll give an example. Suppose you drive a car, we skip a signal and the policeman stops us. What does he do? Police paathitar nammala. He stops us, the car is pulled to the road. What does he does? What the traffic policeman does to us? He identifies the document and he put a fine and he says, please, after 10 of it, we go. First scenario, suppose you kill a person in a broad daylight. A lot of people are there. Someone kills someone. I'll not say you kill a person. So there is a murder or homicide happening. What does the same policeman comes there? What does he do? Same documented. One has killed the other one. What does he has come there? All the people are there. What does he do? He's taken to, he's remanded. He's taken to some jail. Then what happens? Some 1,000 rupees fine was given for jumping a signal. So a fine of 2 lakhs could be given for killing a person. But what does the law do? He's taken to a trial. And we got the advocates who speaks for the person who was killed and for the person who stalks it, and he gathers lot of evidences. We call, did you see how it happened? We call, and the judge makes it. Why? Is because it's a high stake. So our final exam thing, it's a very high stake. We give him an MD degree. He's going to practice from tomorrow. Do we do that? Single day exams are snapshot exams. Suppose he's got a bad day that day. He's fought with his wife. There was some problem in his house. He didn't sleep well. He's got health. Because a lot of children we are seeing, they're coming and no, sir, I'm not going to take exams. I'm just done. So this happens. So can we make a decision on that particular day, on that particular exercise to say that is no? That's literally a wrong one, according to me. So this has to be multiple. So we got various decision frameworks which will say how effective is this EPA function. One common thing is called the A-Rich framework, which based on agency, how involved is the learner, reliability, how much can we rely on his reliability. Tejinder Singh, we used to say it's not reliability, it is reliability. How much you can rely on its ability to do the work. That's what sir will say. Integrity, capability, and all these are taken into consideration while making the decision. And testing, we already know, I'll not waste much time. We know we have got various tools are with us to assess the various part as a part of your thing. It could be knowledge-based, it could be skill-based, based on OSCE, or it could be observation. Basically, very important one, it could be observation, because we have to observe him. We have to give him feedback. We have to correct him, again observe him until he reaches the level of excellence, which could be done by all these workplace-based assessment models. And so best thing is to watch. Don't take a decision from the words of others. Okay, I saw him. He was fine. Don't take it. See for when you are an observer, when you are an assessor, see for yourself whether that particular thing has happened. And just hearing the trainees doing might not help you the thing. Observing will be the very, very important. And look at the trainee product, how he has done the procedure. Look at his product, which will also say the amount of work done by the postgraduate. So it's, as I told you, these are the various ways in which you could observe him, short practice or a long practice observations. And as I told you, what we need is not to put a beautiful set of EPAs, but we have to see whether we are able to work on it, develop milestones, sit with our postgraduates, train them according to the milestones, observe them, and make a prospective form of assessment rather than a retrospective assessment. And we have to develop our curriculum for the EPAs. These 4 questions must be there. What is the work to be done? What must the trainee demonstrate before we trust them to work? How should the trainees be trained? And how should we answer? These 4 questions must be answered in our curriculum document for an effective functioning of the entrustable professional activities. So, a lot of universities, we can map this with the various competencies is there in all the documents. And even we have apps in the mobiles to track the EPAs. So to summarize, what does EPA do? It encourages facilitators to be more observant and articulate. It makes our curriculum an outcome-based curriculum. And it recognizes, as a learner, I feel happy if I know that I have progressed from novice to a mastery. We could adjust our teaching learning method according to it. And it offers a framework for changes in the curriculum implementation. And it may be one of the tools to address the challenges what we have in the present PG curriculum. So what to do? Development of EPAs has become mandatory. It's not that NMC will do and give a set of EPAs to all the specialities like what they give for the 3 volumes of competencies. No, we can, as subject experts, we can sit together, we can and develop our own EPAs, and we could validate our own EPAs and make a list so that it becomes uniform. Suppose I have a set of 36 EPAs are there for PG curriculum in pathology. If it's implemented, all the colleges which does PG program in pathology will have the 36 one. So it's not that, oh, my student doesn't know frozen. No, we are not, we don't have cases of that. No, such things will not happen. So we have a standard set, and the products which come out of this will have a skill set which is uniform among all of them. And we could also make, suppose a particular training is not there in a particular center, we could access, that's the networking. We could ask our friend, okay, see, I'll send my postgraduates, you please train them on that particular thing. So we could have a networking, we could collaborate learning so that our ultimate aim is to make all of them learn and become an expert. And a big thanks for this excellent platform. And if you have any queries, if I know, I'll try to answer. Thank you. Thank you, Chairperson.
Thank you, sir. Among the maze of medical education jargons, sir brought the definition and characteristics of EPAs very lucid and very simple, sir. We really enjoyed that. And sir's comparing and contrasting of the competencies and the various domains among the EPAs was very lucid. And we also enjoyed the design and development of EPAs, and the criteria for the validation of EPAs were very, very clear and simple. And sir also encouraged to design our own EPAs in our institutions. Thank you, sir.
Thank you, sir, for you have bring out the pitfalls and defects in the postgraduate medical education. I think a single examination at the end of 3 years, it's a not ideal one to design the fate of a postgraduate who had toiled hard for 3 years and shouldered the responsibility. I think EPAs prospective assessment over 3 years should be given adequate weightage in passing out the postgraduates. Thank you, sir. Thank you very much.
Now the discussion is open for questions. Any questions from the audience?
Hello.
Yeah.
Sir, there is one small question, sir. Doesn't it impinge on the ethical issues, sir? Because sometimes we entrust an activity to the postgraduate. We know our checks and balances. We know the postgraduate is ready for such an activity. But at times we get the feedback from the patient next day when we go for rounds otherwise. Sir, why did you let the training doctor do it on us? You could have done it yourself. I felt so much of pain. Does it impinge on the ethical issues, sir?
Not that way, sir. Your PG must do as Shivakumar sir does the thing. That's what. That is the level of mastery you develop in him, sir. He must be, the patient must not file that whether Colonel Shivakumar does it or the postgraduate does it. It's almost akin to that.
But on ground, sir, we generally see that the patient understands. He is a senior doctor, he is a junior doctor. So even if the postgraduate does it in a very excellent manner, the next day, a small mishap which we also could have committed, they highlighted to us that the senior doctor neglected us. They made the junior doctor do it. So are there any ethical concerns when we entrust such an activity to the PGC?
As such, ethical is there, but this could be sorted out with the dialogue or talking to the patient, making him come and sit with us and just talk that this is happening. It's going to be a teaching institute, so such things will happen. Something like that it could be.
Thank you.
So we once again take this opportunity to congratulate and appreciate the organizers of DEEPAM Med Conference 2026. Thank you.
Thank you, sir, for your outstanding efforts on a challenging topic. 5 levels and the mnemonics were mind-blowing, sir. I request our chairpersons to felicitate our speaker